يعني غنية عن التعريف، واعتقد الاغلب يعرفها منكم ما شاء الله. دكتورة نهى استشارية اصلاح الاسنان، consultant restorative dentist. She's a clinician who looks at healthcare from the window of quality and patient safety. Dr. Nuha was sitting on your seat a few years back. She graduated from Saudi board program, and then she became a consultant and a mentor in the same program she graduated from at Armed Forces Hospital, Dhahran. She's also holding a master in quality and patient safety from Harvard Medical School. She's the director of CQI department at the same hospital she joined since she graduated. Please welcome الدكتورة نهى. إن شاء الله حنبتدي السيشن الحين، حيخلص بإذن الله تقريبا على الساعة 7. We will take 2 hours. حيكون في break time for prayer at 6:30 p.m. for 15 minutes. وحنرجع بعدها for discussion and for interaction. Kindly feel free to raise your hand anytime to interact. If you have any question or any comment, write it in the Q&A session window. نرجع ونأكد إيش السبب إحنا هنا اليوم. Why quality? Why patient safety? زي ما تعرفوا إحنا هذه quality وال patient safety is not a single person responsibility أو a single department responsibility. وصارت من أهداف الاستراتيجية ومن القرارات اللي approved عن طريق خادم الحرمين الشريفين للمجلس الصحي السعودي. From here I will leave it to our speaker. أسلم الراية للدكتورة نهى. I hope you enjoy the evening and إن شاء الله يكون كله يعم علينا بالفائدة. تفضلي دكتورة نهى.
دكتورة منال، جميعا مساء الخير. طبعا زي ما تفضلت دكتورة منال، الحين حكون البرزنتر لكم today. I'm going to talk about the quality improvement. Yesterday Mrs. Nada Al-Harbi, she joined us in this program and she presented patient safety. So I'll go through the agenda of today. So we'll start with the outline. First of all, I'll start by defining quality, and then we'll define what is quality improvement and what is QI, why is QI important or quality improvement important to you, how to measure quality, can we measure quality or not, and how to measure it, how to improve equality, what are the methodologies used to improve equality, and what is focus PDCA, and examples of healthcare quality improvement projects. Okay, so first of all, I'm going to start by the survey that you have participated in, and we would like to thank Academic Affairs and Training Administration for helping us in pulling out those results and the answers for those questions. So we wanted to ask you and to know what is the background of the attendees about if they had any previous learning program for quality improvement. And we found out like 70% of the attendees, like 2/3 of the attendees, they did not have any background or they did not have any previous learning program about quality improvement and patient safety. And by this, we can think of that you need to learn more about basics of quality and patient safety. And if they have ever participated in a quality improvement project, only 10% they mentioned, yes, I have participated in a quality improvement project, while 90% they haven't participated in a quality improvement project. So if yes, what is the project? Some said that I participated in post-hospital discharge phone. and others, they said writing policies. So there is no clear even title for improvement project that they have participated in. Have you ever faced any problem in the system that requires an improvement project? Interestingly, 57%, like more than half of the residents, they are facing problems in the system that they think it requires quality improvement projects. And I think from this question, actually, we should start to understand the importance of learning about quality improvement at the residence level. There is one saying, I found it out while reading some of the articles. It says making quality improvement a core tenet of how healthcare organizations are run is essential to ensure safe, high quality, and responsive services for patients. So first of all, we will start by defining of healthcare quality. What is healthcare quality? Let's look at the definition of Institute of Medicine. It defines healthcare quality as the degree to which healthcare services for individuals and populations increase the likelihood of desired healthcare outcomes and are consistent with the current professional knowledge. When we say desired healthcare outcomes, what are we talking about? We are talking about the patient outcomes. The patient comes to the hospital, he's expectant, he's going to have a positive health outcomes. It's consistent. So healthcare quality is that the healthcare service is consistent and meeting the current professional knowledge, the evidence-based medicine. So it's aligned with the evidence-based medicine. It's a degree of excellence in healthcare. So the Institute of Medicine, the entity who wrote Crossing the Quality Chasm, where the concepts of quality and patient safety has started and arised, they put 6 dimensions of healthcare quality. And I felt it's meaningless if we didn't cover those dimensions and have a brief understanding of them and what each one of them would mean, because quality is a bit of a general term. So we cannot say quality without being able to measure quality, and we cannot define quality without saying what are the dimensions of quality and what is quality in healthcare. So if we say quality, it means it's safe. Safety means avoiding harm. Like what Mrs. Nada, she said, we've been always learning, do no harm to the patient. So it's avoiding harm to patients from care that is intended to help them. It's timely, so it means we reduce the waits and sometimes harmful delays. So if the patient is in need for a surgery, timely healthcare service is that's going to provide to the patient the surgery that he needs within a timely manner, without delays. If the patient's having sepsis and the patient needs to start on antibiotics, it means the patients immediately should start on antibiotics and there is no delay in the care. There is delay in the care, it means we have a gap in one of the dimensions of quality. Effectiveness, what do you mean if we say this service is effective? It means providing a service based on evidence and which produce a clear benefit. So it means using the evidence-based medicine and managing the patients. Efficient, it means avoiding waste. There is waste in healthcare? Yes, there is lots of waste in healthcare. So efficiency, it means to give the best outcome to the patient with the minimum resources and avoid the waste in healthcare. Person-centered is establishing a partnership between practitioners and patients to ensure care respects patients' needs and preferences. We do the care to meet the patient needs, not to meet the physician needs. Patients are the center of the care. There is a slogan in the patient-centered care says, there is nothing about me without me. So we don't provide care to the patients that's not, the patient didn't decide about or did not select. And the care should be equitable. It means to provide care that does not vary in quality because of the person's characteristics. So if we look into quality assurance triangle, it starts by defining quality and then setting standards and develop indicators. Setting standards is like developing policy and then starting to select indicators and measures to measure quality. After we select the indicators, we start to measure quality and then we assess our quality. And if our quality is not meeting the standards that we expect, at this point we need to improve the quality and then report it. And again, we need to set standards, develop new KPIs, measure and improve the quality. And it's a continuous cycle. So improving quality is about making healthcare safe, effective, patient-centered, timely, efficient, and equitable. So improving quality is to make quality meeting the true dimensions of quality. If we look at the value of healthcare, what is the value of healthcare? Did you hear about value-based healthcare? What is the value? What do you mean by value of healthcare? Value of healthcare can be defined as quality divided by cost. And I'm highlighting this because I want to show how important the quality in giving value to the patient. So if the quality is high and the cost is minimum, then we have a value of healthcare. And what's meant by quality is a better patient outcomes and a better patient experience, divided by the cost, which includes direct costs and indirect costs. So improving quality is going to be reflected on reviewing the value of the healthcare. So what is quality improvement? Well, there are many definitions for quality improvement. Like what Mrs. Nada said yesterday about many definitions of patient safety, still the quality improvement has many definitions. I'm going to look through and stream on your answers of the survey. So what is quality improvement? I'm not going to read them all. I'm just going to scan and read some of them. Maybe at the discussion, some of you can volunteer whether they answer those answers. So quality improvement is a systematic, formal approach to the analysis of practice, performance, and efforts to improve performance. It's the combined and increasing efforts of everyone, healthcare professionals, patients and their families, researchers, payers, planners, and educators to make the change that will lead to better patient outcome. So here they're talking about a teamwork, multidisciplinary teamwork, better system performance, and better professional development. It's the framework we use to systematically improve the ways care is delivered to patients, improve the system or the things related to healthcare community, to facilitate and give easy, faster outcome that serve the medical community. Some of you say, I don't know, لا أعلم تماما. I cannot define it. Better using of all resources. So now we define the better use of resources as what? As efficiency. It's minimizing waste and better use of resources. So it's one of the dimensions of quality, I agree. Improving work efficiency. Again, people look into quality as efficiency. Process of continuous improvement, maximum benefit with minimum waste. So again, it's efficiency. So it's efficiency, but not only efficiency. I cannot define it. لا أعلم. Quality improvement is a systematic, formal approach to the analysis of practice, performance, and efforts to improve performance. So I can see that most of the answers are correct, but it's still incomplete. So let's look at the first definition. It's the delivery of healthcare with improved outcomes and lower costs through continuous redesigning of the work processes and systems. Second definition, it's using a systematic change method and strategy. So the people who said systematic change, they were correct. It's systematic change and methods and strategies to improve patient experience and outcome. And what is patient experience? There is a trend now, by the way, in measuring patient experience and improving patient experience, and it's globally. So what is patient experience? Patient experience is defined as the sum of all interactions shaped by an organization culture that influence the patient's perception across the continuum of care. So patient experience is not patient satisfaction, it's patient perception, but in which way? In the interaction of the culture of the organization. The third definition is an improvement in patient outcomes, system performance, and professional development that results from a combined, like what you said in your definitions, multidisciplinary approach in how change is delivered. So it's a change, it's going to impact patient outcome, it's going to impact patient experience, system and performance, professional development. It results from combined multidisciplinary approach. Quality improvement can be defined as, in summary, the Health Foundation has defined it as a systematic approach that uses specific techniques to improve quality. So quality improvement is to make a difference to patients by improving safety, effectiveness, and experience of care by understanding of complex healthcare environments, applying a systematic approach and designing, testing, and implementing changes using real-time measurements for improvements. So the idea of redesigning the system is an idea of quality improvement, and not only redesigning the system, testing the system. And I'm going to talk about this later on when I talk about some frameworks for quality improvement. So what is the fundamental theory of improvement? The central law of improvement is every system is designed to deliver the results it produces. So therefore, a clear understanding of the system nature and interdependencies is the key to improving it. So in case we have incidents, we have a medication errors, we say, well, those medication errors has resulted because we have some issues in the system that we have to improve. We have a sentinel event. Well, yes, we need to do a root cause analysis and understand what are the system issues that needs an improvement. So Deming's theory, what is Deming's theory? Who is Deming? Deming is an engineer. And he said, he has a major and very well-known theory. It's called profound knowledge. And profound knowledge, the theory of Deming's, you can read more about it and elaborate more about it when you read and understand it, is a fundamental improvement theory. It's grounded in systems thinking and based on the principle that each organization consists of interrelated processes and people that compose a system. Summary or the brief of the system of profound knowledge of Deming's. Deming said, first of all, we have to appreciate the system. So the system is composed of input. Every process has its input, process, and output. So let's say a medication prescription, or let's say I'm giving the medication to the patient. The process is the prescription, the input is the physician, how he writes the prescription, how that process is going on, and the output, the medication is delivered to the patient. The second ways to appreciate the system is to understand that there is multiple levels of the system. The very minor level of the system is where the patient is interacting with his physician, with his nurse, and with his relatives. And we call this one a microsystem. There is a second level of the system called mesosystem, and whereby it's the interaction between doctors and nurses. There is the exosystem, where the hospital, the procedures and routines. And there is also the macrosystem, whereby there are different hospitals are interacting with each other. The patient will be affected if the patient is transferred from one hospital to another hospital. So this is a macro system. So understanding the system in this way is going to help in improvement. The other way to see the system is the Swiss cheese model that Mrs. Nadashi talked about yesterday, where for the error or the source of harm to reach the patient, it has to pass through multiple levels of the system. So this error has to pass through gaps in the system until reaching the patients. It's not the default of one single person. Second is the theory of knowledge. And the theory of knowledge, as you can see, there are two arrows that they are making a circle. So the idea of quality improvement is always a continuous process. We call it continuous quality improvement because we improve and then we need to improve again and then we need to improve again. Psychology of change is not easy to implement change. Is it easy to implement change? It's never easy to do change. So you need to understand psychology of the change and you need to do some kind of change management. There are multiple frameworks for change management that can be used and understand why people are really resisting the change and how to engage them into this change or the new process, the new system, the new improvement that you are going to get. Third is knowledge about variation, and to know about variation. And what is variation? Variation is inconsistency in the process. For example, a diabetic patient is managed differently with Dr. A than Dr. B. Another example, patient identification is done using two different identifiers between nurse A and nurse B. So this variation sometimes can be harmful. The variation is categorized into two types. Something we call it a special cause variation, like for example, a sentinel event, or a common cause variation. And usually the variation that we have in the system or in the process is common cause variation. So we need to monitor this variation in any process by measuring the process, and we need to minimize the variation, because variation, if we don't understand it properly, we won't be able to manage quality improvement in the right way. So why is quality improvement important? And this is a scene from one series called The Residents. So you are the residents, and we want to know, why is it important for you to attend a quality improvement session? Why the Saudi Council are asking you to attend the quality improvement education program? Why are they asking you to participate in quality improvement? And is it important or not? So let's look into your answers. What did you say? You said, why do you think you need to learn about quality improvement? So you said to improve patient safety. Okay. Professional skills, be knowledgeable, can help providers with reliable, cost-effective, and sustained healthcare processes, and enable them to achieve their goal of improving care delivery and enhancing patient outcome. And I like this answer because it says the goal of a physician, or the goal of the resident or future consultant, is to help patients and to give the best care to the patients. And the best care to the patients is not going to be provided by your own efforts. You have to find the gaps in the system that you are working in and try to improve it to get the best care to the patients. To continuously improve care, patient safety, quality improvement tools, no idea, easiest way to deliver the best care of the patients, how to improve the hospital. Some say mortality, safety of care. So there are multiple answers. So it's important to you because better patient and population outcome is linked to better professional development and a better system performance. So those three things are very related to each other, and they reflect each other. Also, engaging in quality improvement enables the clinicians to acquire, assimilate, and apply important professional capabilities, such as managing complexity and training in human factors. So you would learn more about human factors if you work in quality improvement. It's a chance to improve care, to develop leadership skills. Every leader has to know about quality and patient safety, to do some presentations, maybe more frequent than the presentations you do in the residency. It's time management skills. You're going to learn some time management skills to help in career development and build relationships with colleagues in organization that they have recently joined. Also, for more experienced clinicians, let's say for consultants or senior registrars, to address long-standing concerns about the way in which care processes and systems are delivered, and to strengthen their leadership for improvement skills. So the earlier you will be introduced to quality and patient safety, the more you will have the skills to lead those quality improvement projects and to improve the system and improve the outcome and care to the patients. Is it important? Okay, I hear you. Okay, let's look how quality improvement interacts with other approaches to improving healthcare. So quality improvement is interrelated to other activities like clinical audits, like research. Actually, quality improvement is considered a quasi-research. So it's one type of research. It's similar, very similar to research. And there are some differences between quality improvement projects and research, minor differences. It's related to service evaluation and to clinical transformation. So it's related, quality improvement is actually related to any other interactions in the system or approaches to improve the healthcare. It's the core of the other strategies to improve the healthcare. And it's interlinked to all of them. It's related to the clinical auditing, it's related to research, it's related to clinical transformation, and related to the service evaluation. So how to measure quality? And that was one of the questions in the survey as well. So how do you think you can measure quality? By feedbacks and failure or success of the system. So let's say you mean failure and success of the system. It can be considered a sentinel event because a patient death due to medical error is a failure in the system. So it can be. By feedback, you mean by patient satisfaction? It's possible. Depends entirely on the contents and brand promise and service quality dimensions vary according to the industry. Agree. Rate the service right after it's been delivered by using BDSA cycle with defects. نعم. Measure the outcome. Some say again mortality, safety of care. So they're talking about some measures to the healthcare outcome. By follow-up surveys, by certain criteria, outcome. So there are multiple ways and answers that you thought of that we can measure quality with. So why do we think quality measurement is hard? Do you think height is difficult to measure? It's easy. How about weight? Is it difficult to measure weight? It's very easy to measure weight. How about measuring the improvements in weight? Is it difficult to measure the improvements in weight? It's easy because we use the numerical scale for that. How about few things like happiness, love, sadness, joy, fear, anger, quality? Are those easy to measure? I don't think those are easy things to measure. We don't have a scale for quality. So to measure quality, usually we use KPI. So quality cannot be measured directly, unfortunately. An indicator is a surrogate for direct measurement of quality. An indicator is a measure that reflects the quality. So to be able to measure quality, we used what's called key performance indicators. مؤشرات قياس الأداء. So quality measurement is a type of evaluation that is used in many industries. And I could find that one of the answers in the survey have said that it depends on the industry, and you are correct, and you are fully right. So one of the examples is the Environmental Protection Agency. They measure the quality of the air and the surrounding environment by analyzing the presence of specific compounds that are known to cause pollution. So they measure the environment pollution by analyzing the presence of specific compounds. The resulting calculation is known as the air quality index and tells us or tell you how clean the air is and whether it will affect your health or not. So they have developed an indicator to measure the level of pollution, and they called it air quality index. So they measure the air quality. So quality measurement is now increasingly common in healthcare. It's very, very common to select indicators. Methods of monitoring quality. We can do regulatory inspecting, like, for example, SCFHS visits, like Ministry of Health visits to the hospitals. We can do surveys of consumer experiences, like, for example, who is the customer or the consumer of our organization is the patient. So we can do a patient survey, and the most common patient survey done is the patient experience survey. And we can have a third-party assessment, includes what? Includes a JCI accreditation, and we can also use key performance indicator. So according to a scientist, his name is avidis Dunabedian, he said that healthcare quality can be assessed using a three-part model: structure, process, and outcome. So he said the system has three parts, and to be able to monitor quality in this system, we need to define KPIs, but then we have to select KPIs at different levels. So those KPIs are different. They don't look like each other. They don't sound like each other. Some of them are structure, some are them process, and some are them are outcome measures. So what is the difference between the structure, process, and outcome measures? Usually the structure is a number, and it measures the number of professionals, the number of facilities, technologies, how many clinics do we have, how many consultants do we have, how many patients have we treated. Number of patients is structure. Technologies, organizations, and resources. The process is the care that we provide to the patients, like diagnosis. It's usually a verb, or it's like an action that is done to the patients. So it's a diagnosis, it's the therapy or prescription, it's the interaction, it's the leadership, communication, management. So all of those are processes. So what is the outcome? The outcome is the results. So we have some clinical outcomes like mortality, morbidity, let's say pressure ulcer, healthcare associated infection, CLABSI, CAUTI, all of those are clinical outcome measures. So those are results, those are outcome for healthcare system. Functional, and they can be also perception. So perception, for example, like the patient experience is an outcome measure. So I hope this is clear. So we have a structure, process, and outcome of every system. Each part of this model is interdependent. Yes, Dr. Manar.
I know nothing, Dr. Sorry.
It's okay. So good structure usually ends by giving a good processes, and good processes usually ends by giving a good outcome. So the healthcare quality measurement process can be assisted by the use of key performance indicators. Why? To capture a variety of factors and trends of the healthcare system. Please, if you have any questions, don't hesitate to write it in the Q&A part, and then we will be discussing those questions and answering them, inshallah, at the end of the session or during the break. So what is a KPI? What is the aim of KPI? KPI, we said it's a key performance indicator, and we said it's an indicator to measure quality because quality is not easy to measure. We cannot have a scale from 1 to 10 to decide what is the quality in this healthcare system or in this clinic or in this department. So the aim of KPI is to evaluate how well an organization meets the customer needs and operational and outcome expectation. So again, how much this organization meeting the quality, and we said quality is outcome and customer needs and expectation. I think this picture was really popular. I've seen it in Twitter and WhatsApp. So this picture shows how healthcare organizations that's not really measuring, not necessarily healthcare organization, any system or organization that is not measuring KPIs and don't have clear KPIs, and how the KPIs can really organize and do the magic in the system and organization and make it more organized and clean and pretty. So a quality measurement tool, if we want to select a quality measurement tool, we can say that it must be objective. It must be based on scientific evidence. It should not affect or distort the results. And in developing quality measurement, it must be tested to ensure that it is reliable. Reliable means use of the tool results in the same reading regardless of who does the measurements or when and where the measurement is taken. It should be valid. That is why all the KPIs, before they are reported or an improvement project is done based on them, they have to be validated. So the tool measurements measures what's intended, and it should be standardized. Definitions of data elements, data collection, and data analysis are sufficiently precise and comprehensible that they can be understood and applied in the same way, regardless of who refers to or applies them. So it has to be standardized. And to be standardized, usually we define the practical elements in the KPIs, and that include the data elements, the data collection. From where are we going to get the data? Is it from the system or the medical record, or is it from nursing notes, or is it from observation? Like we collect the data of hand hygiene. How do we collect the data of hand hygiene? We do the collection for data of hand hygiene by observation. So we observe the healthcare providers if they are doing the hand hygiene or they're not doing it. So we should collect exactly how are we going to collect the data. We should decide the sample size. We should decide how are we going to collect it, whether the tool we are going to use, it should be standardized. So KPIs are used to systematically monitor, evaluate, and continuously improve the quality of care. Many organizations waste time analyzing the wrong measures, leading to inaccurate decisions, unfortunately. So let's think of structure, process, and outcome measures. And let's see that the structure means how much did we do? Like, for example, in OPD, how many patients have we seen in OPD? This is kind of structure. It's an effort, but it's a structure. How many operations did we do in July? So this is structure. But how well is the process? So how well did we do this process? So how many patients, how far is, let's say in the OPD, how far is our appointments if you want to give a new appointment to the patient? So this is a process. So we can say we measure the available appointment or the third available appointment in OPD. If we look at it, like if you want to know the outcome measure for those, so is anyone getting better off? So in outcome measure in OPD, we can see how many patients, let's say with diabetes, are being controlled. So this is an outcome measure. In OR, we can see how many complications related to the OR procedures are we having, how many for admissions, how many mortality, how many post-surgery we have DVT, PE. So those are outcome measures. So the least important is the structure. So if we can't measure anything, then we have to measure the structure. We can measure the number of patients. The second best is the process. And the most important is the outcome, because we said quality is to give a better outcome to the patients and a better experience to the patients. So let's have some examples of measures name. And here I can give the mic to you so you can participate in giving and suggestion some measurement names, and let's discuss some KPIs. And I can see the participants are reaching 60. So I think we have so many participants. We want them to raise their hands so they can be unmuted and they can participate with us in this part. So let's say an examples of measures, we can say percentage of anesthesia assessment completed prior to surgery. So how are we going to measure this? We have to develop a KPI. And because it's a percentage, so it has to be numerator and denominator. So we will say it's the number of completed anesthesia assessment. And we should define what is the completed anesthesia assessments and then divide it by the total number of patients who require to have anesthesia assessment prior to the surgery. The other KPI is surgical, and is this KPI, anesthesia assessment completed prior to surgery, structure, process, or outcome? So who's gonna participate? Who's gonna participate in this answer? Do you think it's structure, process, or outcome? Any volunteers to raise their hands, please? Otherwise, we'll be selecting. Okay, so we'll use the poll over here. So is the anesthesia assessment completed prior to surgery considered as, if you think it's considered as process measure, then say it's yes or no. Any answers, Mustafa? Good. So 11, they think yes, it's a process measure. Excellent. So it's a process measure. I agree. So let's look at the other indicator. It's the surgical site infection. And if we have residents in surgery, they would understand what I'm talking about. So it's the surgical site infection rate within 30 days of discharge. So is this a structure, process, or outcome? If you think this is a structure KPI, so please say yes. Can we have voting for this, Mustafa, please? Structure. Do you think it's a structure KPI? So what is the structure KPI? It's measuring the number of surgeons, the number of surgeries that is done. But this is infection, surgical site infection. So is it a structure that we require to do the process, or is it a process that we do it, or it's a result of the process? So outcome means results of the process. So do you think this is structure or an outcome? or a process? I don't have a leading answers. And we have someone is raising hand.
It is an outcome.
Who's with us, please? Would you please introduce yourself?
Yeah, I'm Dr. Zahra. I'm family physician.
السلام عليكم.
مرحبا كيفك يعطيك
هلا
العافية.
فيك يعطيك العافية.
This is an outcome. The result
Excellent.
of post-surgery. What is the outcome? What is the rate of infection? So
Excellent. So it's an outcome measure. I agree with you. What a process could be related to this? يعني if you want to have a process measure related to this action, surgical site infection, what do you think the process might be? The process measure.
The cleaning, the preparation of the patient.
Okay, maybe antibiotic.
Antibiotic.
Okay.
Yes.
Excellent.
يعني
Yes.
proper infection control measures to be taken
Perfect.
during the process of surgery.
Excellent. So this is the process measure in relation to this. طيب دكتورة, I would like to thank you so much. Do you have any other comments?
No, thank you. It is very
Thank you
great.
so much. يعطيك العافية.
الله
طيب, so can we unmute the next participant, please, مصطفى?
في دكتورة ناس كتبوا في الشات، دكتورة أميرة، دكتور أسامة، كلهم anyone can feel free to participate.
Excellent. Just raise your hands, please. Okay. Can we unmute Dr. Osama, please, Mustafa?
أهلا دكتورة، حياك الله.
والله دكتور أسامة، كيف حالك؟
الله يبقيك، الله يطول عمرك.
Dr. Osama, we want you to help us with the last measure, hospital readmission rate.
Okay.
So do you think this is a structured process or outcome, and why?
Well, it's an outcome. The hospital readmission rate could be for a few reasons, such as completion of the surgical plan or of the treating physician plan, or it could be a result of a complication that resulted from the initial process.
Excellent. Or maybe early discharge of the patient. Am I correct?
Yes.
Inaccurate or incomplete discharge planning process. Correct?
Yes, exactly, yes.
So this is an outcome measure. There is a new thing I want to add, Dr. Osama, that we have a structured process and outcome. And when we do quality improvement, there is what's called a balancing measure also. And what is balancing measure is a measure that when we do a process improvement, we want to make sure that the second process is not affected negatively. Like, for example, in the hospital readmission rate, it's an outcome, but it's a negative outcome. Am I correct?
I'm sorry, I didn't get you, دكتورة. تعيدينها معليش.
So the readmission rate, do we usually in healthcare system, do we want to minimize it or increase it?
لا, to minimize as much as we can.
Excellent, to minimize. But the discharge of the patients, do you want to keep the patients for a longer length of stay, or do you want to discharge them early?
No, I want to discharge the patient early, as much as his plan serves.
Perfect. So sometimes what happens that the early discharge of the patient, that we work on improving it, unfortunately results by increase in hospital readmission rates. So if we want to improve the discharge, for example, sometimes we need to measure the readmission rate, not because it's an outcome measure. It's an outcome, but it's a negative outcome. And we call it a balancing measure. يعني لما نصلح الاوتكم ما نبغى نعمل negative outcome by increasing readmission بسبب ان المريض طلع من المستشفى وعمل له early discharged that was not aligned with the patient condition.
True, I get you.
Is it clear?
Yes, too clear, yes.
And I hope it's clear to everyone. Thank you so much. Do you have anything else to add?
لا يعطيك العافية دكتورة، شكرا لك.
الله يعافيك دكتور، شكرا لك. So we said we have a structure, process, and outcome. And sometimes in quality improvement, we need to add what is called a balancing measure. And a balancing measure, usually an outcome that we suspect that our improvements might unfortunately affect another measure negatively, like what we said with discharge and hospital admission, readmission rates. So the result for the poll was yes for the surgical site infection. And the answer was incorrect because I said, do you think it's structure? So the doctor who participated with us, الدكتورة اللي شاركت معانا قالت إنه هو ما هو structure, هو outcome. So it's an outcome measure. Right. So can anyone, any other person raise her or his hand, any resident who want to give us another examples of clinical measures other than the measures that we have talked about? Any measure that came up to your mind, you worked with, you've measured, it just popped in your mind now. So any other volunteer? Okay, if so, you can raise your hand. Or should we shift? If no volunteers, I'm not gonna insist. Okay, so we have Dr. Zahra.
Yes.
Would you please? Yes, Salam alaikum, Dr.
For example, the control of diabetes in patient, the control of blood sugar in diabetic patients. This
Excellent.
is
so the control.
Yeah, and even control of hypertension, for example.
So how do you measure it?
If we have a standard of normal blood pressure and with follow-up of the patients, if the blood pressure comes within normal range, this is a clinical outcome measure.
طيب يعني دكتورة ممكن نقول إن الميجر حق uncontrolled diabetic patients مثلا نقول percentage of diabetic patients with hemoglobin A1C uncontrolled. إيش رأيك؟
Yes, yeah. High hemoglobin A1C. Yes. This is
so the measure has to be yes. And also for blood pressure. So we can say the patients, for example, what can you give me an example for the blood pressure uncontrolled? How are you gonna plan the measurement of this KPI?
If with follow-up of the patients and we measure their blood pressure and it comes high, for example, more than 140/90 or 130/90, and already we have standard, which we are template or standard we are following. And if the patient is on antihypertensive, this is a clinical outcome. If the physician, for example, proper follow-up with the patient, yani in general, this is a clinical.
It's a clinical measure, excellent, Dr. And in this measure, if you want to measure it, let's say, in your clinic in the future, you need to develop a tool to collect the data, صح ولا لا? Because you are, or maybe you can review files of the patients. So you can take a population, the hypertensive patients, and review the file of those patients monthly, for example, and develop a data collection tool whereby you are gonna write let's say the medical record of the patient, the medication the patient's taking, and is the patient controlled or not controlled? And then you need to decide the sample size based on the population. So the quality measurement, it starts by an idea and based on a need in the organization. So for example, our major patients who are visiting the OPD or visiting the primary care center are hypertensive. And we think that we are not managing the patients properly. So we start to measure, to identify the problem. And to be able to measure it, we need to be very structured and very clear in what we are measuring. and to be able to based on this measure. يعني كان احنا لما نعمل ريسيرش كيف نكون مرة دقيقين we have to validate the tools. نفس الشيء في quality improvement وفي quality measurement per se.
Exactly.
And after we get our results, we compare it to other results. And this process, I'm not going to go through details in this process in the lecture because it's a kind of simple introduction to the quality improvement. But comparing our results to know how are we doing is called benchmark. And sometimes we benchmark our results with another hospital, or we benchmark our results with international benchmark. So we see, like, for example, the percentage of controlled diabetic patients in the US, and we compare it to our results. Or we can compare one center to one center, or we can compare the results of one doctor to the other doctor. So there are multiple ways to benchmark and compare our results to the other entities, organizations. Some we call it international benchmark, we call it internal benchmark, and we have external benchmark.
Excellent. Great. يعطيك العافية.
شكرا دكتورة. يعطيك العافية. شكرا جزيلا. So how to improve quality? Now let's say Dr. Zahra, she measured diabetes, uncontrolled diabetic patients in her center, and she found that the diabetes was actually not really controlled. So how are we gonna, and how did we decide? We measure it and then we compare it to the benchmark, to the other healthcare organization or to international results. And we found that in our center, we are not really doing well. Whether the reasons are, but our results of controlled diabetic patients is not good. Like, let's say 50% of our diabetic patients are uncontrolled. So we have a problem and we need to do a quality improvement because we are not doing the best care to the patients. The quality improvement is not haphazard, it's systematic approach. And I think all of you, they believe it's systematic approach, and there are multiple ways to improve quality improvement. There is Lean, there is Six Sigma, there are multiple ways to improve quality improvements. One of the most common and simple ways is the IHI model for healthcare improvement. And the model of improvement starts by asking 3 questions. What are we trying to accomplish? What is our goal? How will we know that a change is an improvement? So if we want to achieve our goal, how do we know that we have improved? So we need to measure what we are planning to improve. We want to improve the condition of the control of our diabetic patients. Okay, that's a good goal, but then we need to make it smart. And I'm going to talk about smart goals and objectives later. And then we need to be able to measure it. And how are we going to measure it? So we need to develop a KPI. The third question is, what change can we make that will result in an improvement? So what is the changes that we can implement it, and it might really improve the system and the process? And the changes that we are going to propose, it can be an evidence-based changes. So we can review the literature and see what other organizations have been done to improve this problem, and we implement it. Let's say we have a high rate of surgical site infection. So if we have this in our organization, we can implement bundles for surgical site infection. Let's think we have a high rate of CAUTI. What is CAUTI? Catheter associated urinary tract infection. So we have high rate of CAUTI in our ICU. How are we going to improve it? We're going to implement CAUTI bundles. So there are certain evidence-based strategies that we don't have to argue, and we would know that it's going to improve the system. Sometimes we need to look into some of the projects doesn't really have an evidence-based changes to implement. So by this, we need to look into the system. We need to do some root causes. We need to look into what are the reasons that are causing the problem, and we try to improve it. And then our improvement will follow: plan, do, study, act. And again, you can see the arrows. It's very important that it's a continuous action, and it's a continuous quality improvement. It never has a beginning and end. So now I'll talk about the focus PDCA. So the focus PDCA, actually F-O-C-U and S is an abbreviation. Abbreviation F is a find, and then O is an organize. C is to clarify the process and the current knowledge and collect data. U is to understand the system, the process, the system, how is the complexity of the system, and then to select the process improvements. And then again, PDCA, so plan, do, check, and act. And I'll go through every step a little bit in detail. So F is find a process to improve. So if we have, let's say in the primary care center where Dr. Zahra is working, we have so many problems. We have uncontrolled diabetic patients. We have uncontrolled hypertensive patients. We have a delayed appointment to the patients. And we have so many issues and problems that we have identified when we started to measure and when we developed our KPIs. So now we have so many problems to improve. From where should we start? Which one to select? So sources to identify opportunities of improvement can be KPIs, like we talked about. It can be also hospital committee reports or hospital team reports. Every hospital has its own committees and teams. And those committees and teams sometimes come up with problems. And problems need solutions. So those problems that's been discussed in the hospital committees is a way to identify the opportunities for quality improvement. The other is medical record review. So there is a requirement actually by JCI and SCFHS to have a medical record team whereby they review the medical records and check the documentation. Those results of the medical record review can give an insight for improvement projects. The mortality and morbidity reports, because if the mortality and morbidity reports have resulted in identifying some sentinel events or some cases that we think that we need to do an improvement for, then it's an area for improvement. Also sentinel events and sometimes the incident reports. And I think Mrs. Neda yesterday, she covered the meaning of sentinel event and the meaning of incident reports. So every healthcare system usually have an incident reporting system, and those incidents can be categorized and have thematic analysis and then been identified like a source for improvement. Let's say a patient fall. So a patient fall, we have in this quarter, let's say 15 incidents on patient fall, patients who failed in our organization and resulted in harm to the patient. So those incident reports are a clear sign that we need to do a quality improvement for the patient fall. So what are the possible tools that you need to work with when you want to find the problem? So I want to find the problem. Okay, I'm going to find it in a meeting or I'm going to find it in KPIs, but how am I going to do it? So you can use what's called a prioritization matrix. I'm going to show it later on. You can use a data collection tool. I'm going to talk about it as well. You can use a tool called affinity diagram. I know that most of those terms are new to you, but then let's consider those as the first exposure regarding those terminology. You will have a first understanding. And then when you start to do quality improvements in your center or hospital, inshallah, in the near future or in the far future, you're going to use those tools. The other tool is control charts and then brainstorming tool. I'm going to go through every one of those tools. So prioritization matrix. What is the prioritization matrix? Prioritization matrix is a tool usually whereby it's a table, it's a tool, has calculations. Usually we can put the projects that we want to work on or the problems that we are having, and then the criteria. And we can use the criteria. Usually we use an evidence-based criteria to decide the priority. But this tool, the prioritization matrix, is not to be used only for selection of quality improvement projects. No, you can use it even if you have suspicion and selection anything. Like for example, if you want to buy a car. So you will list the variety brands of the cars, and then you will list on the criteria that's really related to the car. For example, I'm gonna list on the in the area of the project, I'm gonna list a Lexus, I'm gonna list like a Land Cruiser, I'm gonna list a Ford, ما أعرف اسمها السيارات بس let's say a Ford اللي هي family car. So I'm gonna put those cars, then I'm gonna put criteria to select between those cars. So I can select based on the price. And if the price really matters to me, I can put high score on the price. So if the price is really important, I'm gonna double it in comparison to the rest of the criteria. And then I'm gonna list the safety. I'm gonna list, like for example, the size of the car. I'm gonna list the warranty and the post service. And then I'm gonna list different characteristics. So the criteria usually is selected based on the person's selection. And the criteria for improvement project is based on the areas in the organization. So here we have a project for hand hygiene, we have project in patient identification, and we have project in pressure ulcer. And based on those criteria, based on those scores, we can select our priority for improvement because we have multiple problems. Which one to start with? Sometimes this quality improvement needs resources, needs time, needs efforts, needs to develop a new system. So which one to start with? We should start by priorities. Control chart. What is a control chart? Does anyone has worked before with control charts or run charts? If anyone, please raise your hand. I'm willing to give you the mic and talk and explain to your colleagues what is control chart, when did you use it? So control chart simply is a graph used to study how a process changes over time. So in control chart, data are plotted in time order. It has a central line for the average and has an upper line for the upper control limit and lower line for the lower control limit. And usually the upper and lower control limit are the lines determined from the historical data. So let's see a control chart. This is a control chart. So we said the central line is the average. So we will plot our data or our results monthly. So this is the time or sequence. So every month, Dr. Zahra, she will measure the percentage of uncontrolled diabetic patients. I'll keep on reflecting on you, Dr. Zahra, because you are the one who participated. So monthly, you will be measuring your KPI and you will plot it over a graph. So this is going to be monthly. This is your data results of uncontrolled, the percentage of uncontrolled diabetic patients. And we expect that there will be variability, like 1 month, there will be 15%, other months there will be 20%, third month will be 30%, it depends. So usually the data is not in one line. And then we will have the average in the middle. So this is the average. And then we have the upper control limit and the lower control limits. And the upper and lower control limits are really what makes the control chart so unique, because those control limits can tell us signals if we look into the control chart. And is really our process under control or not under control? So there is a variation that we call a common cause variation. It's the variation that is between the upper and lower control limit. And there is a special cause variation where we have sometimes in 1 month, our uncontrolled diabetic patients is reaching 30%, and this is not the normal. And this is special cause might be related sometimes for reasons. So for special cause variation, we need to go and dig and try to look what is the reason of the special cause variation. So why do we use control chart and why is it important to us? It's important because it's going to give us our performance over time. And we would know if there is variation in our performance or not. Variation is not really good. We want to minimize the variation. We want to standardize the process as much as we can. And from minimizing the variation and the upper and lower control limits, having them closer to the average, comes the idea of Six Sigma. And if you heard about the Six Sigma in a way to improve quality, where the upper and lower control limit comes from, it comes from the data itself. And usually there are programs to analyze the data and give control charts. There is an adds in, like UI macros, that adds into the Excel. And there are other systems, other programs and softwares that can analyze the data and give you a control chart. The other is the run chart. And the run chart is very similar to the control chart. The difference between the run chart and the control chart is that in the run chart, we don't use the average, actually. We use the median. And we don't have upper and lower control limits. What is similar to run chart and control chart that we are always plotting data over time. So always in this axis, we have the time for the run chart. As you can see here, we have the week. Sometimes in quality improvement, when we do a quality improvement, we need to measure our median or average if we are using control charts before and after improvement. So what is a brainstorming tool that we can use it with our team to know which area is high priority and which one to start with by improvement? So it's a process of generating creative ideas and solutions through intensive group discussion. So in brainstorming, we try to discuss the problem with the multiple stakeholders, with the teams, with the people responsible in the organization for this problem. And everybody should participate. Every participant is encouraged to think loud and suggest as many ideas as possible. Usually in brainstorming, there is no stupid idea. Every idea should be valid and accepted and should be added to the ideas that we are going to discuss and think of. Then they should analyze the ideas, we should discuss it, and criticism is not allowed. Brainstorming is to use the collective mind to meet goals and objectives, to find solutions, to overcome challenges and solve problems. It's better to have enough ideas for some of them to be wrong than to be always right by having no idea at all. This is why we should always encourage the team to come up with creative ideas, to give whatever comes up to their mind as a solution to the problem. And then we can evaluate it and check, is this applicable? Is it feasible? Is it easy to do and implement? But we should never ignore any idea. Data collection tool, examples of data collection tools. So if you want to collect the data, how are we going to collect the data? We can use questionnaires like what we said and the patient experience surveys, or we can do questionnaires like the culture of safety survey. I think many of you has participated in culture of safety, and if not in the past, future you will be participating in culture of safety survey اللي هي ثقافة السلامة. طبعا هي قاعد تقاس الحين مركز سلامة المرضى على national level. So all the hospitals are participating, and we are having a national level culture of safety results. And then also the interviews. You can interview patients, you can interview healthcare providers to understand the problem and try to collect data. You can do observations like what we do in hand hygiene data collection, and you can have a checklist. And the most popular data collection tool and checklist is the safety surgical checklist. This is an example of data collection tool. So this is a table that has a data collection tool. Other tool is Pareto chart. So what is Pareto? This is Pareto. So what did he come up with? He used to highlight, his tool is used to highlight the most important among a typically large sets of factors. So let's say that we try to learn about a problem. We have a medication error. So we try to list the reasons of the medication errors that we are having. And then after we list those problems, we need to identify which one is the most important. So Pareto came up with a chart that can help us in doing this task. It contains both. His chart contains both bars and line graph. And it's very unique chart. I'm going to show you in the next slide. The values in this chart are represented in descending order by bars. So the problem will start by descending order, not ascending, descending. And then cumulative total is represented by the line. And he came up with a rule, it's called 80-20 rule. And it's very famous rule. It's called 80% of the effects are coming only by 20% of the causes. So this is example of Pareto chart for type of medication errors. So we have a problem that we have so many medication errors in our organization. We measure the medication errors, and usually medications error are measured by incident reports. So we measured it, and we found that we have so many medication errors, and it's a big issue that we need to improve. So what are we going to do? We're going to have the reasons between those medication errors, and we're going to list it by bars. So this is a bar graph. Bar graph is used to analyze data if we have different categories. So here we haven't used line graph, or we haven't used run chart or control chart, because we have different categories of the problem. So we have dose was missed, we have wrong time, we have wrong drug, we have overdose. All of those are the reasons for having the medication error. So we want to know which one we should focus on and improve, which one we need to educate staff about, which one we need to develop policy about, which one we need to implement a system proofing to the error. So we have listed those problems starting by the highest problem. So the highest was dose was missed. The second was wrong time, then wrong drug, and then the reasons from less. So this is, if only this graph is done, only the bars, it's called bar graph. But what's unique in Pareto chart is that Pareto is drawing this line, the maroon color line also. So this line is showing us where is the cumulative percentage of those errors. And it's showing us that 80% of the problem of the medication error is coming from those two reasons: the dose missed and the wrong time. So if we're going to reduce the medication errors in this hospital or this center, we need to focus on two things: the dose missed and the wrong time. That's it. We should not focus on an authorized drug or technique error or wrong IV rate or underdose, because those are not really major factors in having the medication errors in this system. So what is affinity diagram? Affinity diagram is a tool that gathers large amounts of language data. Let's say we made a brainstorming and then we had so many ideas, or we had so many opinions, so many issues, and then we organized them into groupings. So we got those ideas, we got those problems, and we try to group them based on their natural relationship. After we group them, like in this graph, we can see how can we solve them based on the grouping. So let's say reasons, this is an example, reasons why patients are not on a standardized anticoagulation pathway. So we have seen that the patients are not on a standardized anticoagulation pathway. So what is the reason? It might be education, because we think there is no orientation, there is no medication reconciliation, no regimen for post-op patients requiring warfarin. This needs education. It might be related to communication. So we get all of the ideas and the reasons that we come up with in our discussion or our survey or our feedback, and we gather it into thematic analysis. And this is, we call it affinity diagram. So let's have some examples of titles for improvement projects. Reduce the patient's waiting time in OPD. Reduce patients' waiting time in ER. We can take, let's say, patients category, triage number 3, and we can see how long the patients are waiting, and if they are waiting or exceeding the expected waited time. So we can say we want to reduce the patient's waiting time in ER, and this is a safety project. We can say reduce inpatients and safety and timeliness. It's not only safety, it's safety and timeliness, because we are reducing the waiting time and trying to provide the best care to the patients in a timely manner. Reduce the inpatient average length of stay. And this we can consider it as efficiency. Improve OR utilization by increasing the percentage of utilizing the OR. And this is also efficiency because it's going to minimize the waste. If the OR is not really occupying the patients and the patients are getting into waiting list and the OR is working but not full capacity, it's a high cost on the organization and it's not used efficiently. So it's a waste. Reduce the turnaround time for diagnostic tests. And this is a safety if it's like for critical patients. So organize a team that knows the process. So after we find the problem and we set the title of our improvement project, we will do a team. We need to organize a team because we cannot work only by having one team leader. There should be a team that works together in the improvement project. So always remember, happiness is working with great people. So select great people to work with you in that team. So usually there's the team leader. So what are the responsibilities of the team leader? Team leader responsibilities is coordinating all the team efforts. He's the person who provides, he or she is the person who provides guidance to the team members as needed, assigns the team function as appropriate, reports the team performance improvement measure, usually to the quality and patient safety department, because usually those projects are followed up and reported to the senior teams and committees. طيب, who is the facilitator? And what is her or his responsibilities? The facilitator of the team is the person who assists the members in measurement, in understanding of the statistics and etc. So he's the person who's gonna have the quality mindset, the person who's gonna help them in the measurement and developing the KPIs, how to do the sample size and understanding the statistics and the data analysis. He's gonna develop and revise the necessary if there is any policy and procedure for the assigned function, and he or she is gonna assist the team in summarizing the representation to the management of the project and which stage are they reaching in the project. Should they do another cycle of improvement? So the person who's gonna really give them the quality improvement tools. And then we have team members' responsibilities. So what are the responsibilities of team members? Team members usually are maintaining a current awareness of all requirements regarding the function. And how to select the team members? Team members has to be selected based on the process. Yani if, let's say, we are doing a project in the OR utilization, whom are the people who are involved in this project. We will take a nurse from OR, a frontliner, and then we'll take a physician who works in the OR, so a surgeon probably. And then we're going to take a senior leader, so we can have, let's say, the medical director to be the team leader. And then we can have a representative from the quality department. We can have a member from the supply if the issues are related to the supplies. We can have a member from any other department that we think is related to the process or the improvements. Then we will, so first of all, we will maintain, his role is to maintain a current awareness of all the requirements regarding the function. Second, developing and revising the necessary policy and procedure for the function assigned, and then understand, document, and simplify the designated process, and then complete the assignment in a timely manner. So the team leader is going to instruct every team members on what to do, and the team member has to do it and submit it in a timely manner. And then implementing actions necessary for the improving performance. So after we organize the team, we will start to do meetings with the team, and then with the team, we need to clarify the current process and understanding what is the problem that we are having, what is the current process. So first of all, a full understanding of the current process by all the team members is very important. To be able to understand the process, you need to draw a flow chart to clarify the process variation and the problems. And then you need to collect data from all affected areas relevant to the process and the desired outcome. So flow chart, how to do a flow chart, it's not difficult, it's very easy. You can even look into, you can Google it and you can look how to do a flow chart, and there are some softwares that can help you very easily develop a flow chart. So the idea of the flow charts is that you are gonna go through the process step by step, because sometimes you can identify unnecessary steps. You can identify some steps that's causing delay to the process. Some steps are waste in the process, and sometimes you can redesign the process to make it better. So you need to understand the process, and to understand this properly, you need to do a flow chart. This is an example. A patient came to the ER with surgical disease for operation. So this is the start, and usually we put this oval shape in the start. So how to do a flow chart for this process? Start, patient come to the ER, ER physician examine the patient. Then we need to think, do we have triage for the patients or not? Is this ER physician is the triage doctor or not? We don't know, but this is the current process. So the patient's coming to the ER physician is examining the patient, ER physician requests for surgery specialist, and then surgery specialist examine the patient, and this is the end of the process. So if we look into this process, we might identify some gaps, and then we need to improve it. But first of all, we have to understand the process, exactly how it's going. And usually we do a flow chart by reading the policy and by observing the process itself. So we can go to the ER and we can see how the patients, when they register at the ER, how they go to the different processes until they reach the OR. So if the patients need an admission, this is continuity of the process. Patients need an admission. No, then give medication and discharge the patients from the ER. And it's the end of the process. The patients need an admission. So whenever we have an options at flow chart, we put the diamond shape and we can have a yes and no. And sometimes those arrows can be connected based on the process. The surgeon decides admission and operation. So then the next step, preoperative operation as per the policy. So we need to develop a pre-op policy, or maybe we have a pre-op policy and maybe we don't have. Operation is done and documentation is completed. We have a report, and then post-operative care, discharge, follow-up in the OPD, and this is the end of the process. So after we understand the process, we can decide how to improve it. So understand the causes of the process variation. So we could understood the process and how it's going by a flow chart, but then is it always going this by this consequence or the steps? There's many causes for process variation. And sometimes we have a policy. The standard is to follow the policy, but the variation is very a lot, it's maximum, and we're not really following the policy in every step. So how to understand the process? Identify tools to describe, analyze process variation, do root cause analysis and desired outcome, and I'll talk about the root cause analysis. Obtain information from benchmark and best practice. So, okay, we have seen our flow chart. Is this flow chart acceptable? Is this the correct process in managing, let's say, patients with a stroke coming to the ER? Is there an evidence-based guidelines in managing patients with stroke? Is there a certain steps that we should do whenever we identify patients with stroke in the ER? So we should always ask the questions to be able to understand and reflect on the process and how is it done in our organization. Does it need an improvement or it doesn't? And we compare it to the best practice and other guidelines and updated evidence. Third is identify all possible solutions to achieve the desired outcome. The main difference between quality improvement and research is research sometimes doesn't look into the root causes of the problem in an organization. It's mainly based on implementing certain change packages that is evidence-based. But quality improvement is very customized and specific to every single organization. So what's work in hospital A might not fully work in hospital B, because hospital A has different culture than hospital B, has different system, has different people, has different IT system. So in quality improvement usually is customized to the organization. So this is an example of fishbone diagram. It doesn't really look like a fish, but it's similar to a fish. So this is the head of the fish, and here we have the CS complications. So we have complications, the cesarean section, and we try to find some reasons behind the problem. So for every problem, we have usually many root causes. And to get to the root causes, usually we ask 5 whys. So this is a fishbone that is summarizing the machines, methods, manpower, and material that is related to CS complication. For example, we have no PPG, we have as a machine OR monitor problem, improper sterilization of equipment, improper suture material, bad quality of suture material, unqualified nurse, unqualified physician, whatever is the reason. It might not be all of those reasons. But usually the fishbone diagram is ending up by having a lot of fishbones, because usually the problem that we see, it has many roots that's related to it. It's not only single problem, it's multiple factors in the system. 5 why, we should always ask 5 why, and they said 5 is the 5 why technique was developed by Toyota. It's not by healthcare. And they found that the 5 why technique is very effective when they want to improve their cars and when they want to improve the manufacturing of cars. Why 5? Because they think usually if you ask less than 5 is not really enough and sufficient. So this is an example. Let's see. Why is there an oil on the floor? So we came to a place and there is oil on the floor. So we should ask, why is there an oil on the floor? So the answer, oil leaks from the cylinder rod when activated. In a factory, this example in a factory. So why did oil leak? So we should not only fix it by fixing the leaking, we should ask, why did oil leak? The oil leak is, the answer is the O-ring was cut. So why was the O-ring cut? The rod was flawed. So why was the rod flawed? Dirt in the oil abraded the rod. So why did dirt get in the oil? So there are holes and gaps on the upper plate of the tank. So would you expect that this might be the root cause of the problem? If you ask only one question, no. So if you ask one question, oil leaks, okay, we will fix the cylinder. And then you will buy a cylinder. And then again, after 3 months, there will be a new oil leak because you did not fix the root cause of the problem. So usually if you don't find the root cause of problem and you make an improvement project for this, the problem will keep on recurring and you will have a waste in management. So usually you should start by identifying the root cause of the problem and then try to fix the root cause problem, to fix the problem and prevent it from happening again. Should we go for break, Dr. Manar?
ايش رايك دكتورة نهى ناخذ بريك 10 minutes عشان it's 6:30 sharp now.
Okay.
طيب what time you want to come back دكتورة نهى? 6:40? 10 minutes?
Yeah, I think that would be good.
Okay, so everybody, inshallah 6:40 sharp, we will continue. What do we have دكتورة نهى after the break? بعد إذنك.
We'll continue with the Focus BDCA tool. So we will continue with the 5 whys, and then we will go through the steps of the Focus BDCA tool, and that's it. That will be the end of the lecture.
طيب يعطيك العافية. في بس announcement أحب أقوله، حتلاقوا في الشات في اللينك تبع الإيفالويشن تبع الكورس، وفي 2، في واحد تبع امبارح تبع الأستاذة ندى، وفي واحد السيشن اليوم مع الدكتورة نهى. Please take just a few minutes، قصير جدا ما حياخذ منكم more than 3 to 4 minutes إن شاء الله، بس علشان تساعدونا إنه improve ما احنا قاعدين نتكلم عن quality improvement عشان improve إن شاء الله الquality حقت هذه الكورسز حتى في future. And one more thing إن شاء الله في material في article جزاهم الله خير يعطيهم العافية الدكتورة نهى والأستاذة ندى حيرسلوها بإذن الله لنا علشان نرسل لكم إياها بالإيميل وحيكون في لينك حق open book exam. You can do it anytime. Once you finish the exam إن شاء الله you will receive electronic certificate تجيكم كلكم على إيميلاتكم اللي استخدمتوها في التسجيل للكورس. Please if there is any comment just write it down في الشات أو في Q&A. See you إن شاء الله after 10 minutes.
بإذن الله تعالى. شكرا دكتورة منار. دكتورة منار.
هلا دكتورة نهى، تحبي we continue? Yes, تفضلي. I hope everybody is back. طيب مصطفى. تفضلي دكتورة.
شكرا. Is it clear the full screen دكتورة منار؟
هو بس أي okay. No, perfect. Thank you.
Now it's clear صح؟ شكرا.
Yes, thank you very
much. So the other example of the 5 whys is an example of the Washington monuments. So I think lots of you have visited this area. So one of the examples is that they use so many chemicals to clean it. So they asked, why do we use many chemicals to clean it? Because of the strong chemicals, so it was eroded, okay? So the Washington monument was eroded, and they were asking, why does it need maintenance and it was eroded? And the answer was because of the strong chemicals needed to clean it. So why did it need many strong chemicals to clean it? Because there was lots of pigeon poo on the monument. This is a true story. It's not a fake story, it's a true story. And you can find it even on YouTube that they found based on asking 5 whys, what is the root cause of the problem? So then again, they asked why, and because there were lots of spiders at the monument. So why there was many spiders? Because there were lots of flies and moths. And why there was lots of flies and moths? Because the lights were turned on at dusk. So the solution for this problem, because they were keeping on maintaining this place and because they were using strong chemicals, was not to stop using the chemicals. The solution was to turn the lights on later and stop the chain of the causes. So they just modified the way and the time they turned on the light, and that was the root cause of the problem. So after you try to understand the problem, when you want to do a quality improvement, you can now select the process for improvements. So the changes selected, you should now start to select the changes. So the changes that you select must be smart. So your goal must be smart. That means the objective must be, what do you mean by smart? Still, it's an acronym, it's SMART. So it's a specific, measurable, achievable, relevant, and time-bounded. So we will have an exercise. I will show some goals. And I want to know if those goals are considered smart or not smart. Specific, it means it's very specific to the process that you want to measure. Measurable, it means we can measure this improvement. Achievable, it means our target, we can achieve it. So there is a target that we can achieve it. And it's relevant, so we are measuring something that's related to the process. And it's a time bound, so we can say like, we will achieve this goal or we will improve this project within 3 months. Like for example, we want to improve the OR utilization in, let's say, a hospital within 3 months to be 60%. So this is a smart objective or smart goal for an improvement project. Let's look into this, and please, Mustafa, if you can turn on the poll with us. And let's see, reduce the waiting time of patients. Is this a smart objective? Please answer yes or no. Reduce the waiting time of patients. Do you think this is a smart goal? Mustafa? We can read the chats until Mustafa, he joined. Okay, so I can see the answers, yes, yes. Okay, yes. So can we have one volunteer from the people? Okay, answer please in the poll. And I want one volunteer quickly to tell me why he or she answered yes. So those are the results of our. Can you see the results?
Yeah, it was just here, but I'm checking if someone raised their hand. You want to pick someone, Dr. Nuha?
maybe دكتورة حصة. She is with us.
دكتورة
حصة, would you please raise your hand? Okay. دكتورة زهرة.
Yeah.
أميرة. دكتورة تفضلي.
It's not smart because it is not time bounded. There is no time limit.
Okay, let's look at it.
It is specific. It can be measured.
Good.
It can be achieved. It is relevant, but there is no time bound. We should
دكتورة. Okay.
دكتورة أميرة كمان raised her hand.
طيب.
دكتورة
تمام. شكرا دكتورة زهرة. I will reflect on your answer. Yes, دكتورة أميرة. تفضلي.
السلام عليكم.
عليكم السلام ورحمة الله دكتورة. حياك الله.
I would say that one will be smart goal because we can set a time, we can set objective, and we can meet it. I mean, it is specific, measurable, achievable, and relevant. And it is time bounded too, because we can set a time, and by comparing to that, we can say whether it is really achieved or not. It is smart.
Okay, Dr. So first of all, I would like to thank you for participation, you and Dr. Zahra. Second, I want to say that what you are saying that we can, but this sentence does not reflect those standards. So this sentence, does it have achievable goal? Does it say which percentage are we going to improve reduce the waiting time with? So are we going to reduce it by 50%, by 3 hours, by 2 hours? How long? Is it specified in this sentence? No, it's not specified.
Yeah, it is not.
So, it's not. So this sentence per se, what you are talking about, that this waiting time can be measured. So we can make this goal into SMART goal. But if we have a project that's our goal is to reduce the waiting time of patients, I can see this is not specific because I don't know which patients. Is it OPD? Is it primary care center? Is it patients in OR? Which waiting time? Is it patients in dental department? Which waiting time and which patients? In which center? Which hospital? So it's not very specific. Is it measurable? Yes, we can measure it. We can reduce the waiting time. So waiting time is a measurable thing. So yes, it's measurable, but it's not specific. Is it achievable? We don't know because we did not set a target. If we say reduce the waiting time, for example, of ER patients, category 1 ER, let's say category 2, reduce the waiting time of triage category 2 patients in the ER department to be, let's say, 5 minutes. So here we have set a target, and then we should look into this target. Is it achievable or not achievable? But this sentence is not setting any target. Is it relevant? Yes, if we put a target that has time, yes, it's relevant to the waiting time. But if the target is not talking about minutes or hours, then it's not relevant to the waiting time. And then is it time bound? This sentence is not time bound. It doesn't say within 3 months, within 4 months, within 1 year. We don't know how long the project will take. It might last forever, because it doesn't say how long the project will take, صح?
Yeah, sure.
I agree. So let's, دكتورة خليك معانا، دكتورة أميرة ودكتورة زهرة اللي هي معانا. Let's look into the other. Example. So let's look into the other example. Reduce staff absence. So Dr. Amira, now after our discussion, do you think this is smart?
We have to put our
talent.
Just like this, no.
Exactly. So like this, no.
No. Yeah.
Agree with you. طيب, can you shift it in a way to be smart? Goal?
Yeah. For example, we can say reduce ER staff time or staff absence by 50%, for example. Yeah, within this coming 2 months, for example.
Perfect. So it's perfect. Now you made it a SMART goal. So if you are, for example, I don't know what's your specialty, but if you are the head of the ER one day, inshallah, in the future, if you are studying in the ER residency program, I don't know, but if you are a head of department or even a member in any department, you can suggest SMART objectives for projects that are going to work on improving the system.
Yeah.
Thank you so much, Dr. Amira. Any other volunteer? Dr. Zahra, are you still with us?
ايوه دكتورة ايوه.
طيب دكتورة. So let's look into this, Dr. Zahra, and do you think it's smart or not? And if you can rephrase it to be smart, if it's not, so what do you think?
Improve, what is it? OR, operating theater means operating room?
Yes, OR room. OR is operating room.
Room utilization.
OR utilization يعني كم نسبة الوقت اللي في الOR اللي يكون في عمليات قائمة. يعني ما هو وقت مثلا between transferring the patients، مثلا بين مريض ومريض يجلس غرفة الOR فاضية 4 ساعات، فالOR utilization هو measuring the use of the OR.
Okay,
it's international measure.
This is not smart because we should specify.
Why do you think? Yes.
Improve operating room utilization. Where is it? In hospital? Is it in? We should specify where. And
in a system, for example, let's say in Eastern Province, private hospitals, which hospitals are we going to improve OR utilization? Okay, if we are talking at our hospital level, we can say OR utilization is specific.
Yes,
because we have only one OR, صح?
Yes, okay. And we should measure by how much percentage. We want to utilize it by how much? Is it by 50%, 20%? We should measure it. And is it achievable to utilize it? Depend on the situation. Is this target achievable?
صح.
It's relevant or to the organization or
relevant
not?
يعني relevant للproblem. يعني are we measuring what we are trying to improve ولا لا؟ يمكن احنا المشكلة اللي يعني ما نحلها في الOR ما هي الOR utilization. فهل احنا are we using this measure that's aligned with the project? Yes, let's assume انه yes.
Yeah, and over how long? Over 1 year, over 6 months? We should specify for how long.
Thank you, Dr. Azra. Thank you so much.
يعطيك العافية.
Allah يعافيك. So next, after we have selected this improvement project, we have organized the team, we have finished the focus part of the improvement. Now we will start to set our plan. We need to start acting on the plan. We need to check our performance, and then we need to act. So let's look quickly on every element of those. So what is a plan of improvement? How to set a plan? Plan usually has this format. If you want to do an action plan, it should contain what is to be done, who is responsible to do it, how is he going to do it, and when this person will give the results. So every person should have a task. Like in the OR utilization, we have, let's say, multiple tasks related to review of the waiting list, like observing the process. So every single task should have a responsible person time and how is he going to achieve this task. This is a tool called Gantt chart. Usually they do it electronically. It shows the time. It's used in project management in general, not necessarily in quality improvement projects. And it's used to show the action plan over time. So it's a bar chart that shows the task of a project, when each task must take place and how long it will take. So for very complex and big projects, we can do what's called like a Gantt chart to show every person and when is he going to start, when is he going to finish his project. Second is you do. So you do it. You do it by implementing the best solutions that you stated in the focus process. So you identified, for example, that you have increased number of CLABSI patients, that's the central line associated infection, in your ICU. And this is a big burden in the organization. It causes mortality. It causes high cost in the organization. So you organize the team that you want to improve this action, and you selected implementing CLABSI bundles. So you selected the best solution, you have to start implementing it. You make the forms, you start to distribute the forms, you educate the staff, and you try to empower all the people involved by training, education, and moral support. And here where you can implement the change management, because people might resist this new change that you are asking them to do it. Then you need to collect data and update the checklist and the data that you have. See? is check the status. So now you implemented a new change, you implemented a bundle. You want to make sure that this implementation has resulted in the desired outcome. So you measure again. You measure before the improvement and you measure the problem after the improvement. And then you compare the data and you check if any unexpected, undesired consequences or outcomes, is there any improvement by the change you have made or not? That is why it's a quality improvement, because we implement and then we check our improvement. Let's say this is a graph show expired stocks of certain drugs in a warehouse, and it shows before and after, and it shows how the improvement has happened in the medication warehouse. So was there an improvement? In 2015, it was 10, while in 2016, it was 4. So our actions did not result in improvements. Act is, it means you will continue on implementing and maintaining the gains. So you will work in the A letter, you will work on sustaining your improvement project. And sustainability is a very big concept to talk about. So sustainability is, we don't want to improve the process now while we have a team leader, team members who are working together. We want to improve it and sustain it and interlink it to the current system and make it a day practice of everyone and make it a new process and system. So how can we act? We standardize the process, we adjust the documents, we empower the people if the objective is achieved. If improvement initiative is not reached, then we will not do act, we will report, we will repeat the focus PDCA cycle. And then for both situations, we need to continue to monitor. So if we haven't achieved the target yet, we need again to start a PDCA cycle, and then we will continue in monitoring. If we achieve the target, we will sustain the gain, and we need to spread the action. So if we implement one action in one unit, let's say the medical ward, and we found it's very successful, then we will start to spread the change over the different units, and we try to sustain the gain by having the process to be more sustainable by integrating it into the system. Thank you so much. And please, if you have any questions, raise your hand.
يعطيك العافية دكتورة نهى.
الله يعافيك دكتورة منار.
أنا أشوف ما شاء الله كثير comments، بس كلها comments حلوة.
الحمد لله. أتمنى يعني أن فعلا المحاضرة كانت مفيدة وأن ورشة العمل كانت مفيدة، وأتمنى أن كل resident حضر المحاضرة هذه إن شاء الله يطلع بنيو mindset. يعني هي equality is a kind of دكتورة منار is a mindset, and having those إن شاء الله future consultants having this mindset of quality improvement and patient safety really can make the difference. So every one of you can really make a difference in his or her organization. You can be a leader for quality and patient safety. And remember, you didn't join medical school unless you want to improve the healthcare and you want to help patients. So remember always that if you participate in improving the system, you can always help patients, maybe sometimes in a higher scope or in a bigger, let's say you will have a bigger impact if you try to modify the system and do an improvement projects. ودائما منار أحب أذكر إن شاء الله بإذن الله تعالى، دائما أحب أذكر الآية بالقرآن الكريم اللي تقول ومن أحياها فكأنما أحيا الناس جميعا. فإن شاء الله كل بالضبط، فإن شاء الله بإذن الله تعالى الله يجعل كل عملكم في ميزان حسناتكم، وإن شاء الله تكونون future quality and patient safety champions in different and multiple hospitals.
إن شاء الله إن شاء الله. ما شاء الله عندنا جروب مميز الحقيقة دكتورة، ووجودهم الحين that the fact that they are here لين هذا الوقت و they took from their time وجالسين معانا لين هذا الوقت، يعني اليوم خميس ويك اند والناس عادة تاخذ اجازاتها. The fact that they are here it shows you how يعني how special ما شاء الله trainees هذول حقونا. فإن شاء الله يا رب يعني
صراحة
نتأمل منهم الكثير. طبعا ما شاء الله يعني كلها التعليقات كلها في الشات. دكتورة thank you دكتورة, outstanding presentation, marvelous effort, great presentation, very beneficial. يعني أنا شايفة كله ما شاء الله يعني amazing comments ما شاء الله. ماني شايفة أحد حاطط questions أو شيء. تحبي دكتورة توجههم لبعض الريسورسز المفيدة اللي ممكن يرجعوا لها لو هم حبوا يعني يستفيدوا أكثر غير الارتكلز الله يعطيكم العافية اللي حترسلوها زي ويب سايت learning resources كذا.
تمام. طبعا if somebody is interested to learn more about quality and patient safety طبعا في ال HRQ website is full of references. في ال IHI اللي هو Institute for Healthcare Improvement also is full of references and documents about quality improvement. They do online training, online courses. Also there is the CBHQ program whereby you can have a certificate by having an online exam. You can prepare for that by attending some courses, learning about the quality. But I think now you have the basics of quality and patient safety. You are all like now in the learning phase. You can spend some time reading about quality and patient safety, and you can have it like it's not a specialty to go through it as much as it's like a skills and a way of thinking with those problems and would be able to improve them, and it might give an impact, a better impact to the patients. And I think that's what drove me, or that's what was triggering me, my internal, it was my intrinsic, let's say, intrinsic motivation in getting into quality and patient safety. So I hope I try to like put some intrinsic motivation in every one of you to work on improving quality and patient safety.
والله دكتورة big impact لأن أشوف في من الأسئلة يقولوا لك can you elaborate how to get a quality diploma or master certificate, which is I believe you just answered it إنه هي it's not only the certificates يعني it's the practice, it's the passion, it's the continuous improvement. There are so many certificates, but I believe we have seen both in the practice. يمكن دكتورة نهى تعرف هذا الشيء أكثر مني. We have seen people who are interested in quality. They have done amazing job قبل حتى لا يحصلوا على هذه kind of certificates. من continuous development themselves they done. وفي ناس بالعكس أخذوا masters وأخذوا diploma وأخذوا شهادات من أعرق الجامعات. لكن when you come to reality, the practice whatever they learned, that was the real challenge الحقيقة.
صح، أتفق معك دكتورة منار، وأعتقد أن the quality and patient safety, the earlier it starts in education is the best for the healthcare providers. So now it's starting with residency programs. At our time, it wasn't a residency program. We got it after graduation. And sometimes it was by, let's say, a new program that we want to join, we want to learn about. But now it's integrated in the residency program, so it's very good. In the future, it might be integrated in the curriculum of the undergraduates of the universities and the colleges and the medical colleges. I think some of the resistance that we find in quality and patient safety in the healthcare system usually is related to physicians and doctors. And this reason might be related. I'm not talking about really evidence-based studies, but it might be related that those are not really interlinked into the education programs. While in the nursing, they study always about quality and patient safety. So the earlier is the better, I would say, and having it as part of the residency program is excellent. And like what you said, it's more about knowledge and practice. So the next step now for the people who attended the course is not to stop at this level, is to really participate and be initiative in being part of quality improvement projects in their centers. And definitely all of the centers are having quality improvement projects. There is no hospital now that doesn't have a quality improvement projects or doesn't يعني ما في مستشفيات الحين ما تشجع على التطوير وعلى تطوير الجودة. فأكيد كل المستشفيات في هذا الشيء. They just have to be initiative and being part of the quality improvement projects. I'm quite sure they're gonna learn a lot.
إن شاء الله. في كمان أحد قال إنها it's an attitude as well الquality. تأكيدا لكلامك دكتورة نهى، إحنا نعتزم إن شاء الله في الانستيتيوت بالتنسيق مع الquality department على السنة التدريبية الجديدة إن شاء الله we will integrate residents effort في quality improvement projects. حنسوي لها إن شاء الله آلية خاصة بالتعاون ما بين CQI department وما بين الادمنستريشن وما بين مدراء البرامج إن شاء الله، علشان تصير يعني البنفيت to the maximum بإذن الله. One last thing، في أحد سأل عن الليكتشر. دكتورة نهى تحبي تتكلمي عن الارتكلز اللي حترسل بعد كذا والأوبن بوك إكزام؟
شور. طبعا أنا وأستاذة ندى ومع دكتورة منار فكرنا إن إحنا نعمل kind of يعني exam. إحنا we don't want to make your life difficult، بس نبغى نتأكد إن الجميع حضروا والجميع كانوا فعلا engaged، وممكن بعضكم كانت المعلومات سريعة عليه فيمكن يحب يرجع يقرأ بعض المعلومات. ف we thought of making an exam that's going to be like an open book exam. It's going to be emailed to your email that you have registered with, and then we will send you some material to read. You can also search on the internet, and then we expect that you fill this exam and forward it again to the academic affairs, and then after that you would be receiving your certificate. I hope this is not an extra effort or it's so difficult to be done. It's going to be something simple just to make sure that you're going to really have the full information that was intended or was part of this education program, was the goal of this education program.
Yeah, and one last thing, please لا تنسوا تعبوا لنا evaluation forms. Again, it's posted for the last time في الشات. يعطيك العافية مصطفى، شكرا جزيلا لوجودك. نعجز عن الشكر يا دكتورة نهى، يعطيكم العافية أنت والأستاذة ندى.
جزاك الله خير.
الشكر الجزيل الشكر الجزيل للترينيز المميزين اللي كانوا معانا وحرصوا وحبوا وتفاعلوا. شكرا لكم، إن شاء الله الله ينفع الجميع. شكرا للإيفنت تروب that helped us a lot صراحة في technical support and they made this possible. مصطفى ما شاء الله ما قصر معانا وأزعجناه طول الوقت، في كل وقت وإحنا نرسل له ويرتب لنا، يعطي العافية. فشكرا جزيلا يا مصطفى، شكرا للجميع.
شكرا جميعا لكم على حضوركم وعلى وقتكم، والله يجعل في ميزان حسناتكم
الجميع يا رب إن شاء الله. طيب تصبحوا على خير جميعا.
مع السلامة.